Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines are in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the left of your webinar. You may also download a copy of today's presentation using the resources pod located below the Q&A pod. It is now my pleasure to turn today's conference over to Dr. Michael Schmidt. Sir, you may begin.
Thank you, and welcome to The Road to Resiliency, a discussion of the importance of preparedness and response. I'm Michael Schmidt. I'm a professor of microbiology at the Medical University of South Carolina, and it's my honor to be the moderator for this particular webinar. This webinar is brought to us by the National Mass Violence Victimization Resource Center, which is affiliated with the Medical University of South Carolina located in Charleston, and it was sponsored by a cooperative agreement from the Office of Victims of Crime, specifically in the Department of Justice. The opinions that you are going to hear this afternoon are those of the panelists and myself, and not necessarily those of the Office of Victims of Crime or the U.S. Department of Justice or our respective employers. So again, thank you and welcome. I'm going to briefly review our learning objectives. At the end of this presentation, or our discussion, you, the attendee, will be able to describe the advantages of addressing mass violence incidents through a systems-based approach. Secondly, we hopefully will be able to enable you to understand how the careful and systematic consideration of the continuum of issues that arise during the victim's recovery can facilitate the desired endpoint, which is, of course, an improved outcome for all. And finally, we hope that you, the attendee, will be able to lead a discussion where you can consider the factors that are necessary and sufficient for training not only your staff, but more importantly, the next generation of clinicians who will be needed to be able to respond to these mass violence incidents. So, as part of an introduction, this is the third webinar in our series on the road to resiliency. The first webinar we had is available on the American Hospital Association's website for you to be able to review, and it reviews the resources that we have available for us. But first, I'd like to introduce today's panelists. And we have three distinguished surgeons, trauma surgeons with us. We have Dr. Glenn Tinkoff from the University Hospital System, and he's System Chief for Trauma and Acute Care Surgery for the University Hospitals in Cleveland, Ohio. He is also a professor of surgery at Case Western Reserve. Our second panelist is Dr. Michael Cheatham, who's the Chief Surgical Quality Officer of the Orlando Regional Medical Center. And our third panelist today is Dr. Ronald Stewart, who's the Professor and Chair of the Department of Surgery of the UT Health San Antonio, which is a component of the University Health System in San Antonio, Texas. Dr. Stewart is also a member of the American College of Surgeons Committee on Trauma. So, as I was saying in the beginning, the NMVVRC, or the National Mass Violence Victimization Resource Center, is an integrated team that was assembled at the Medical University to specifically address the issues of our increasing number of mass violence attacks that we are seeing across our nation and across the globe. And our vision is victims and survivors of mass violence must have access to first-rate, evidence-based information and services throughout their entire recovery process provided by victims' assistants and other professionals who are delivering compassionate, who are well-trained, and respectful of the victim's needs and wishes, as well as those of their family, and of course, the needs of the healthcare system who are providing those services. Our mission at the NMVVRC is collectively to improve community preparedness as well as our nation's capacity to serve victims recovering from mass violence through an integrated approach through research, planning, training, technology, and collaboration. Today's webinar is a component of that collaboration that we are doing in concert with the American Hospital Association, and collectively we are introducing the importance of this necessary and unfortunate discussion that we must have about mass violence incidents. So the Office of Victims of Crime has a specific definition of a mass violence incident. This is the intentional, violent criminal act for which a formal investigation has been opened by a law enforcement agency. Generally, this is the FBI, but it can be any law enforcement agency, and they're specifically looking for a victim where they might have incurred a physical, emotional, or psychological injury to warrant them opening the case. And in a mass violence incident, it just simply needs to have a large number of people that need to have been affected by the intentional, violent criminal act. And then that opens up resources and opportunities for victims to seek assistance and compensation from the responding jurisdiction where the mass violent incident has taken place. As you see on the left-hand side, we have two very disturbing incidents that really set the tone of what our discussion here today about preparedness and response should get us into. Namely, we have the shooting that occurred in a Florida high school where a shooting rampage went on within the school, resulting in a very tragic outcome. And the second image is that of a shooting that took place in Las Vegas, Nevada. We actually did a webinar on the Las Vegas shooting associated with an outdoor concert. And if you're interested in learning more of how the hospital systems in that area responded, we had the two CEOs discuss that incident in a webinar that is available on the same website that you have accessed to gain entry into this particular webinar. So the lessons that we have learned in the study of crime and mass violence incidents are manyfold, and they are not surprising when you step back and think about it. Exposure to a violent crime and mass violent incidents is highly prevalent, unfortunately, throughout the United States. Many of the victims do not develop mental disorders, but many do. And these are a component that we need to consider when we are contemplating an appropriate treatment path for the patients that are undergoing our care. Many of the victims, fortunately, recover on their own, while others may need significant assistance, and social support is often one measure that has been found to be protective in helping those victims in their recovery. The image on the left is our leader of the NMVVRC, Dr. Dean Kilpatrick, who has had many years of experience in victim services and responding to crimes. And And Dr. Kilpatrick is a clinical psychologist, and he is well-versed in developing solutions to help individuals recover. The bottom line of all of this, and this is a poll that the Gallup organization conducted in 2019, and the ripple effects associated with these mass violence incidents are nearly half of those surveyed in the United States feared becoming a victim of a mass shooting. The slide image, "I don't want to die," is really the sentiment captured by that polling. Individuals are very fearful of a mass shooting incident. They are becoming more frequent, unfortunately, in the United States, and the consequence is quite disturbing to everyone who has to deal with this on a routine basis. And finally, the problem in brief is laid out pretty much as we see it. These mass violence incidents and other large-scale criminal incidents are often occurring with increasing frequency. Large-scale criminal incidents that have many victims are, an example would be what happened in Flint, Michigan with the water supply. They often can produce deaths, physical injuries, health concerns that many hospital systems may not be able to immediately deal with on the volume and scale that they would like. And this then results in an increased risk of physical and mental health problems amongst the survivors, and we are understanding what is actually going on in this situation. The ripple effects often extend far beyond the direct victims. They often impact the victim's family, the community that the victim is finding itself in, and it can have long-term consequences for those particular areas. So now we're going to get into the meat of our webinar, and so I'm going to set up the scenario using Las Vegas as the example. The code is called, you're responding to the code, and I'm going to ask our panelists to think about these three questions. What are our preparations enough? This effectively goes through everyone's mind in the emergency department as they hear the initial call of the call. They are wondering, is everything at the ready? Will we have enough staff? Will we have enough supplies? What do we need to do in order to ensure that we will preserve the life of those affected? Secondly, what do our staff and communities, and then perhaps most importantly, but oftentimes not considered to the full extent, what do the victims require? And again, this is a three-part question. Immediately, we obviously want to attend to their immediate need, but at the same time, these victims, as well as our staff, have short-term and then, of course, long-term needs in order to recover from the particular code. And finally, the last question that we're going to interject throughout our discussion is how should we be thinking about training our next generation of clinicians who will need to be able to respond and become members of an integrated care team that will provide services in the unfortunate incident as our healthcare systems respond to these mass violence incidents. So I'm going to open up with this first discussion element where I'd like our panelists to think about and offer for our consideration how the intersections of trauma and behavioral medicine, along with the social and physical services that are required, can impact on the healthcare system immediately, short-term, and long-term after the event has happened. And our goal is truly to facilitate better outcomes. So I'm going to toss it first to Dr. Glenn Tinkoff from the University Hospital System of Cleveland and the Professor of Surgery at Case Western Reserve. And I'm going to ask Glenn, what do we need to be doing during the preparation and then our response phases? And then, Glenn, I'll let you toss it to one of your colleagues on the call. Glenn?
Well, thank you, Mike. From the preparation standpoint, our trauma centers, relative to the last 20 years, have developed under really a concept of verification and validation of services. One of those is our preparation to receive and be the acute care facilities in a disaster. So starting back in 2001, 9/11, that was evident that we weren't as prepared as we could be. I think the Committee on Trauma and my colleagues have done an extraordinary work in further preparation. So what does that mean? That a trauma surgeon, usually the trauma medical director of a trauma center, is a member of the Emergency Preparedness Committee of those hospitals. These are a broad swath of individuals who are involved in preparation. Joint Commission is required, and so does trauma center verification processes require that we participate in 2 drills each year and are active participants, and that we know our disaster plans. So our preparation for the activities that are occurring, and I think a testament is both individuals, my colleagues here, have been involved in multi-casualty events. We're well prepared. Myself, I feel like I have a multi-casualty or a mass casualty event every weekend in Cleveland, in East Cleveland. So I mean, those events, those almost daily events that we have of violence, prepare us and prepare our teams to receive multiple patients at any given time. It's the aftermath of that much of this we have not prepared for, and I think that's where this webinar is important to address those measures. I'd like to pass this on to my colleagues. Dr. Cheatham is from Orlando Regional Medical Center, and of course the Pulse shootings were a major mass casualty event of our time. Mike, could you give us some insight in this question?
Sure, happy to. It's really an honor to be here. To answer the first question, were our preparations enough? So we had spent probably 20 years planning for a mass casualty event. We knew it was inevitable. We drilled regularly, as you just mentioned, but I'll tell you, you can never plan enough. Every mass casualty event is different. You just having one drill is not enough. You need to drill all kinds of different scenarios. And I think what we learned out of the Pulse event was that we had spent a great deal of time planning for taking care of patients. The reality is that mass casualty events are just what you do on a normal basis, is just on a larger scale. And so how you take care of the patients, it gets accelerated. You need more resources, perhaps, readily available. But the thing that we really, I think, had not fully appreciated, and one of the things that we've tried to pass along as the points learned, was the impact on our staff, as you've outlined on this slide. Nobody comes to work in healthcare expecting to be the victim of mass violence. We, the Pulse nightclub is 2,100 feet from our emergency department. We could hear the gunshots going off. The entire hospital was part of the hot zone, was part of the lockdown of the area. At one point, we thought there was another shooter in the hospital. And so we had SWAT teams searching the entire hospital, trying to find this other shooter. We had team members that had to barricade themselves into offices and rooms, both in the emergency department and elsewhere in the hospital, because of the thought that there was another shooter. So this has tremendous effect on the team members. And that went on for several years, the people worrying about whether such a thing could happen again. So the mental health aspect of it is something that we don't typically discuss as we plan for mass shootings. We also didn't really plan for families as much as we thought. We certainly had a plan in place, but we had over 500 family members that were congregated outside of the hospital, all wanting to know what had happened to their loved ones. And unfortunately, there were 49 fatalities in the club, in addition to the 44 victims that we received. And so we had family members and loved ones looking for patients that, unfortunately, victims that had been deceased in the club. And so we had to very rapidly ramp up our family plans of how we were going to provide them with information. And then, of course, it was a crime scene. And so the FBI was reluctant to allow us to give out information as yet because they wanted to complete their investigation. And so all of these had tremendous mental health effects on the team members, certainly the patients, as well as on families, first responders, and the community in general that felt like it had been violated. So there are a number of things that one has to plan for beyond just how to take care of the patients. But I'd be very interested in hearing Dr. Stewart's thoughts on this as well.
And Dr. Stewart, being from San Antonio, you had a similar mass casualty incident, but it was not 2,100 feet away from your doorstep. It was a little bit further away. Dr. Stewart?
Yeah, so that's exactly right. It's amazing, though, the parallels, Dr. Cheatham, that I would say all those things that you talked about, we very similar, but it was a beautiful sunny November morning in San Antonio, November 5th, 2017, and we were both of my colleagues are in ACS, American College of Surgeons Verified Trauma Centers, and we had a focused site visit for a PI, and so we actually had an ACS site visit going on that Sunday morning. So at about 11 in the morning, we had an active shooter start firing at a small rural church that was 29 miles away from Brooke Army Medical Center, San Antonio Military Medical Center, a level 1 trauma center, and about 40 miles away from University Hospital, which is the other level 1 trauma center where I was, or we were. In 7 minutes the event was over, but in that 7 minutes, about 46 of 50 people were shot with a high-velocity weapon, and 25 of them were dead on the scene, and the others were transported to hospitals and distributed seamlessly, really, to a level 4 trauma center and to the 2 level 1 trauma centers. So I think, echoing a couple of points of my colleagues, I think this is a really important discussion. It's critical to prepare for these mass casualty, mass shooting events, because if the Sutherland Springs First Baptist Church shooting tells anybody, anything can happen anywhere, and it may not be right next to a trauma center. And so I would say things for preparation is that obviously preparation is key, but a critically important part of preparation is having a trauma system. A trauma system, which is there's no question, and the data are overwhelming that trauma centers and trauma systems save lives. And really, though, one of the ways that happens is through communication and cooperation. If you think about these mass casualty events, it is really chaos initially. We've heard, both at Las Vegas and Orlando that it's really that it's extremely cloudy. You can't see. There's confusion, and really the initial information is almost invariably all wrong. And so having a system in place that can sort that out, because those communications are far more important during these events, and they're far more likely to be clouded during the event. So having communication and cooperation as a system are key. And one of the things that, and we've talked about this, we're in the COVID-19 pandemic, and having that trauma system, emergency healthcare system, where hospitals and health systems are working together, cooperating with each other, even if they're normally competitors, having them cooperate and communicate with each other is critical in these events. We call it co-opetition, actually having competitors cooperate. And so a trauma system achieves that goal. So and then asking what people need, what staff and what the patients need. From the patient point of view, really they need excellent cooperation and communication across the entire health system, spanning the different hospitals in the region and EMS agencies. And they obviously need bleeding control and great multidisciplinary care, particularly multidisciplinary surgical care. And really, that's what's really an ACS level 1 trauma center is designed to do. And so they need that great care, and then they need psychological support, as we've taught, long-term psychological support and peer support. And really, from a staff point of view, I'll just echo what you said, Dr. Cheatham, is that these are very different events. We deal with a lot of, we've all said we deal with multiple small-scale events all the time, but these are really different. It's very different to be talking to a family member, and you're talking to them about a loved one who's critically injured, and really they're asking you questions about other family members, and you realize in the discussion that those family members are not in your hospital and they're not at BAMC, so that means that they didn't survive the scene, and so it is very different psychologically. And so I think having long-term, immediate and long-term peer and psychological support are really, really important from the provider, from the physician standpoint, and also from the patient standpoint.
So, Dr. Stewart, let me ask you a question. Do we need to effectively do a specific form of drilling, or do we need to modify our drill process to effectively consider mass violence or mass casualty incidents, or are our drills at this point in time sufficient to elevate the issue that you so eloquently just laid out for us?
So I think drills are really, really important, and I view that as one of the strengths of Orlando, and that they're. I'll let you talk about Dr. Cheatham, but their drilling process was really exceptional ahead of the event, really through basically learning. We all meet and talk about those things. We had done a tabletop drill 6 months earlier that initially people thought, oh, this is really kind of a little far-fetched, but that tabletop drill was critically important. So we had all of the trauma centers, we had all the EMS folks in the room, and so drills are really vitally vitally important. They're only helpful though if you do them. They're only helpful if you do them. That's another part of being in a trauma system where people are working together. You're far more likely to do these drills if you're doing them in context of a system with all of the hospitals and people are meeting, because it's, we're not humans, even though we know, I think we all know on this call, obviously, and I think probably all of our audience who's listening knows that, that this is going to happen somewhere in the United States again, and it's going to happen, it's going to happen, but since they're really low probability events, it's hard for us to wrap our heads around that, and people sort of, it's a natural human tendency to think, well, this is not going to happen here. But I think as these events have shown, in particular, I think Southern Springs, if it can happen in a small rural church on a Sunday morning, it can happen anywhere, and it is going to happen. And so, but doing it together in the context of a trauma system, I think leads to better drills, like so you can get all of your EMS colleagues, you can get your hospitals involved. So the drills are really, really helpful if you do them. But if you don't do them, they're not helpful. So for the people listening on the audience, I would ask, have you done an active shooter mass casualty drill in your hospital this year? And if not, I would ask why not. The other thing I would say is that drilling is not enough. It's important, but it's not enough. It actually takes a system. It takes a system of care. It's just like managing a hospital or health system. Leadership is really important, but being able to implement is also critical. And so having a trauma system that exists on a daily basis where people actually share information and work together is critical. It's because in I think Las Vegas is a perfect example of this, is that it's not just one hospital, it's multiple hospitals, and patients are going to show up at people's they're going to be taken by private vehicle to hospitals all across the region. So having that trauma system, and really I think having a regional medical operations center as a part of that disaster is critically important. And I would ask, if you don't have one, and if you're not certain what a regional medical operations center is, that's a question that needs to be answered.
Well, I live in a hurricane city, so we well understand regional operation centers and the value that a regional operation system affords any hospital and any healthcare system, because an integrated approach, and I think you hit the nail directly on the head, which takes me to our second question, and this was brought out in the discussion, so I'll toss this to any of you that wish to respond, is what do we need to consider for the recovery of our staff and our community subsequent to these mass casualty events? Dr. Cheatham, Orlando was really struck hard by the incident at the Pulse nightclub, and Orlando has recovered, but there are probably still many scars. So could you share with us what we need to be considering as we prepare and then respond to these MVIs?
Sure, and let me, if I can, for just a couple of seconds, really emphasize what Dr. Stewart was just talking about. The planning, the multi-agency planning is essential. And so we had actually drilled a mass casualty shooting 3 months before the Pulse event that included almost 20 hospitals in the area, included the trauma centers, our trauma system. On the morning of the Pulse shooting, it was almost as if we had already experienced it in a way, in that we had already drilled for having large volumes of shooting victims come into the hospitals in the area just 3 months before. We had recognized where our system had not operated properly. We had made those changes to our disaster plan. And so everyone was familiar with what we had recognized we needed to do better. So drills are essential in that regard. The morning of the Pulse shooting, victims were actually transported to 4 different hospitals. The majority came to the Level 1 Trauma Center, Orlando Regional Medical Center. That's where almost all of the victims' families came to, because that's where the media and the county government told them to go. But we did have some victims that were transported by ground, just as Dr. Stewart mentioned, to community hospitals. So for those hospitals that say, oh, I'm not a trauma center, my plan is just to send the victims to the trauma center, what I would say is that's not a plan. And so you will see victims be brought to you. There were 300 people in the Pulse nightclub. They basically tried to get away. They ran in every direction possible, jumped into cars, and just started driving. And so we had hospitals that were 15 miles away receiving victims that drove in under their own power, just as Dr. Stewart mentioned. The thing that I think is important in the aftermath is to recognize that this has an impact on your staff and on the victims and on the community that will go on for years. I would say that we have not recovered here. We still have a number of victims that are still very traumatized by this. I drive by the Pulse nightclub to and from work every single day, and there are frequently people still there, as it's now a memorial. You have to plan for the mental health aspects. So by 7 a.m. that morning, 5 hours after the shooting, we already had our hospital psychologists ready to meet with team members as they were going off shift. And that was hugely helpful. And we counseled about 1,500 team members in the first week after the event. Like I say, some of those team members are still receiving counseling now almost 5 years later. But you have to plan for that. That's something that is rarely planned for, of how you will deal with the mental health aspects of your team members, how you'll deal with the mental health aspects, the injuries that victims and families encounter, but you really need to plan for that. You also, Dr. Stewart talked about the importance of planning and drilling with the other agencies in the area. And so that becomes very, very important, because on the morning of Pulse, we knew many of the law enforcement people by first name. We already knew their phone numbers. And so when we needed something, we already had a relationship with them that we would not have had if we had not done those drills. The FBI agent in charge made a critical statement on the morning of Pulse that I'll never forget. And he basically said that if he's having to introduce himself at the time of an event, he said he's already behind the 8 ball. So as part of your planning, you really want to get to know all the leaders of the various law enforcement and first responder agencies so that you're not having to take that time in the middle of a crisis.
And can
I think that is, please.
I was going to say, and I think you can kind of see the parallels between, 2 very different parts of the country, very different events, but you can see there's so many parallels in that. One of the things that, if I was talking to a group of surgeons, that I would say about this is, and I work with some surgeons who are, they're great at improvising in a difficult situation. They're outstanding. It's actually inspirational to watch people. They really improvise, adapt, and overcome in difficult situations. And I think hospital leadership is the same. I've seen our hospital leadership improvise and adapt and overcome through many events, but the pandemic right now. But one of the things that I would say is that for these large-scale events that happen so quickly like this, it really does require structure and planning and a trauma system and drills, because you cannot improvise your way out of this. You just cannot. It's too big. It happens too quickly, and it very quickly goes from a local event to a regional event to an international event. And I think the only reliable way to get to that structure and planning is to actually have a system in place that does smaller scale events of these every single day. So the people who are, if you think about those small events that happen, car crashes, falls, shootings, stabbings that a trauma system deals with, those are they're not drills, but basically they are preparation for a wide scale event, and that always works better if you have great communication and cooperation in the system itself.
And so that effectively helps you in the response phase, because with each successive event that you successfully overcome, like the car crash or the weekend gun shootings that Dr. Tinkoff was talking about, you better prepare your system in order to accomplish this. And this will take us to the third question, and how shall we train that next generation to realize the value proposition that a systematic approach affords our response to these events?
This is Glenn Tinkoff. I did want to comment on the past question, and I'll start off on
Go
this.
ahead, yes,
yeah,
please.
The prior question, I think Dr. Stewart and Dr. Cheatham both addressed it nicely. One of the things is the fact that those relationships, that integration between social and mental health services and what's usually thought of as trauma services, which is really clinical care and are multiple specialties, including emergency medicine, neurosurgery, orthopedics, our trauma surgeons, and our anesthesiologists, our nurses. Is something that a trauma system addresses. It's the foundation, those collaborations. Having them in place, having them work every day in those collaborations make a much stronger and resilient system. And that's why we're better prepared. Now moving on to what do we do? What do we need to consider for staff community? I mean, how shall we train the next generation, and how can we achieve this? The next generation is marked by work hour restrictions, rightfully so, by a major understanding of technology beyond which somebody at my age just is not going to have. And those are benefits of that generation. They have unique learning and training styles that we need to address. And they are a more diverse generation in many ways, and have great capabilities of managing problems like this, as long as we keep them alive in their educational curriculums. That's hard to do. These are what if moments, and it's involving them and involving them early and identifying those, especially our future leaders in this field, very early, and that the Committee on Trauma does that, and it's leadership programs, as well as many of our professional organizations, is try to to identify the leaders of the future in our field, and also make sure that emergency preparedness is important, as an important element in our training and our education, and that we participate in these drills at the highest level, not only the drill itself, but the debrief that has to be performed after the drill. I'd like to pass this on to my colleagues to also discuss the future of training.
Dr.
Thank you, Glenn.
Dr. Tinkoff, I'm going to answer just kind of, because I think I can give a simple answer to this. Is that I think training the next generation, it's critical that we have high-functioning level 1 trauma centers, ACS verified level 1 trauma centers. Those centers, one of their specific missions that makes them different from all the other levels of trauma centers is they're tasked actually with training that next generation of leaders, both from a physician, surgeon standpoint, emergency physician, nursing, tech standpoint. So I think having and preserving the critical role of level 1 trauma centers is key, and because it's like the trauma care from a healthcare point of view it's not just transactional from purely a business standpoint. It's training these next generation of leaders is really the role of those level 1 trauma centers. And I think any progress that I've made, that we've made, has been the result of people who came before me in our local area, they were really committed to that mission. So I think the role of the level 1 trauma center is critical to the system.
Yeah, this is Mike Cheatham. I would definitely echo those comments. We know from the literature that the care that victims of these mass casualty events receive as part of a trauma system, we know that care is more likely to restore them to health and have a good outcome. So where we have trauma systems, we need to continue to develop those. Where we don't have trauma systems, we need to develop them. We need to develop a system that is going to be able to take care of victims of these events, whether it's a mass shooting, whether it is a hurricane, whether it is any type of disaster that leads to mass casualties. These events don't occur every day. A surgeon, a trauma surgeon, might have one of these events, a large-scale event, occur in their career. And so I think it's important that for the next generation that we pass along what we learned. It's one thing to learn from the operation or the patient that you took care of last week, and you learn from that so that next week maybe you'll do it a little bit differently. With a mass casualty event like this, you don't have that luxury. You can't learn from your own experiences frequently. So it's important that we pass the lessons that we've learned from these events on to the next generation so that they can learn how we might have done things better so that they can provide better care to the victims that they encounter in the future.
I think from a real-world situation, Dr. Cheatham and Dr. Tinkoff, I'm just thinking back to those events, and I think because we're in the pandemic and we're not able to physically meet, but whenever I think back, just the sequence leading up to November 2017, is that I learned so much from the Orlando team at the TQIP meeting, the large American College of Surgeons Trauma Quality Improvement Program meeting. I learned a lot from that interaction in that meeting. And then a month before, there had been the Las Vegas mass shooting, where I was on a panel with the team from Las Vegas and learned so much from them. So I think preserving those educational opportunities on a big scale where people share these events, because it's really true what I didn't think of it, Dr. Cheatham, but it's just what you said, is that maybe some of these events hopefully are like once in a lifetime for the teams who are involved, and being able to share that experience is critical.
So that sort of takes us to our closing thoughts. And what I'd like each of you to do is to share the lessons learned and a specific message that you'd like to share with the CEOs and hospital leadership so that we can inculcate these values of the importance of drilling, the importance of debriefing, and how best to ensure that we have an empowered next generation. So I'll just toss it out to whoever wants to go first, and we'll go from there.
Yeah, this is Glenn Tinkoff. I'll certainly the two individuals that have had the experience of a mass casualty event should end this session, this webinar. What I will say is what you've heard mirrored here is the importance of trauma systems, and understanding what a trauma system is it's just not the team in the ED or 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 ICU, but it is an expansive clinical providers in trauma care, including our mental health professionals, our PM&R, physical medicine and rehabilitation colleagues, and our medical social workers, and our communities and our EMS workers. That is the network that's going to save lives in these events. And we must, to the administrators and certainly CEOs, facilitating their lives, making their lives better, will make this work better.
Well, thank you, Dr. Tinkoff. Dr. Cheatham or Dr. Stewart?
Sure. So,
Sorry.
It's a tall order to come up with the lessons learned. What I would suggest is all of these trauma centers that have dealt with large-scale mass casualty incidents in recent years have published papers in the literature on the lessons learned, and I would really encourage your listeners to avail themselves of that knowledge. There's some really excellent articles out there that describe the lessons learned from multiple of these events. I guess what I would say is you have to drill, and Dr. Tinkoff and Dr. Stewart have both elaborated on this as well. You have to practice. You're never going to become a concert pianist by just walking up to a piano. Same for professional sports. You have to practice. You have to plan multiple scenarios. You have to drill multiple scenarios and mass casualty incidents so that you can become facile at dealing with those. Just a couple of things that we really had not completely probably planned out adequately for during the Pulse shooting. Obviously, family, as I've already alluded to. You have to have a plan for the family and how you're going to cope with providing them with information, as well as dealing with those that are grieving because their loved ones didn't survive, as Dr. Stewart mentioned. But one thing that we had not really planned on was the media. As Dr. Stewart mentioned, it becomes an international event. So the hospital was completely surrounded here by the news media for the first week. And we had to rapidly escalate our media plan to deal with the hundreds of news reporters and television trucks that surrounded the hospital. Law enforcement, you have to develop those relationships now. We really benefited from the relationships that we had, but those relationships became much, much stronger following the Pulse event. And we now drill regularly with our law enforcement colleagues and have a much better relationship. But you have to have a relationship with your local government. because there are going to be things that they need from you and you're going to need from them. And so having that relationship ahead of time, again, is essential. I guess what I would say in closing is you will encounter a mass casualty event at one time or another. It is inevitable. It may not be a pulse shooting. It may not be Las Vegas. It may not be any of the mass shootings that we've seen over the years. Maybe something smaller, but it still may overwhelm your facility, and then it becomes a mass casualty event. It would be a shame if a patient succumbed to their injuries because you weren't prepared. So I think it's incumbent on all of us to take the time to plan for disasters and make sure that we're ready.
Well, thank you, Dr. Cheatham. Dr. Stewart, closing thoughts?
Yep, and I think we're running short on time. I'll try to be brief. I think whenever I look for opportunities for improvement that we had a really strong, good system response. But I think Stop the Bleed education and training, we had done a lot, but we hadn't made it to a small rural community. The idea of doing Stop the Bleed education where you turn bystanders into immediate responders is a great community engagement tool for hospitals and health systems, so doing more Stop the Bleed education training. Whenever I look at, these events can be prevented. I think we get an F for prevention with respect to some of these events, and there is a path forward for firearm injury prevention, which a lot of people in the trauma community have spearheaded, which is nonpartisan and basically goes something like this: make firearm ownership as safe as reasonably possible and work to understand and address the root causes of violence. And so we also learned we had sort of in its infancy a whole blood program, but the ability, sort of cutting edge to get whole blood to the scene, that was an opportunity I think that we can do all across the country. And then the last thing is about the interface between psychological and physical trauma. Is I think in one word, one short thing is really doing trauma-informed care at an institution level really gets to that peer support and that engagement. So doing trauma-informed care from a psychological point of view is a lesson learned. Thank you.
Well, thank you, Dr. Stewart. Those were very welcoming words, because it takes us to our next discussion, which will be webinar number 4, where the code is over. And we have 3 points that we are going to, again, address. And we are fortunate in that we're going to have Anna Newcomb, who is the president of the American Trauma Society, join us, along with Aurelia Sands-Bell, along with Ann Seymour, and a victim of one of these mass casualty incidents, who are going to talk to the importance of recovery and rebuilding. So on behalf of the National Mass Violence Victimization Resource Center and the American Hospital Association, I would like to thank our panelists, Dr. Glenn Tinkoff, the professor of surgery at Case Western Reserve University and head of trauma at the University Hospital System, Dr. Cheatham from Orlando, thank you as well, and Dr. Ronald Stewart from San Antonio. We thank you for your participation with us today. So on behalf of everyone else, I'd like to thank you for your attendance, and I'm going to turn it back over to Brandon.
Thank you, ladies and gentlemen. This concludes today's event. You may now disconnect your lines, log off the webinar, and enjoy the rest of your day.